Samir asked me, what are the things which has changed for me in COVID? So I've included some of those which personally has changed to me in COVID. After COVID for me, what is in and what is out? My safari suit is out. On a daily working basis, I have stopped using it. Now it is only a pant and a shirt. Evening OPD, it is completely out. It's only in the afternoon I work and in the operations which are there in the mornings. And all evenings I am with my own wife. Out are socks and shoes. While working, out are socks and shoes while working. In is only the sandals most of the time, and whenever possible, sports shoes. Now with the aging process, which I realize I am getting old, so out is increasing the wealth, and in is reducing the wealth. It's a difficult job, still trying hard. And many friends have volunteered to help me. I'm making a list of those who can help me, all are welcome. Out, now in orthopedics, out is treating ankle fracture without a stress test. We used to feel that if there is a fractured ankle, we used to give them a plaster, which is no more valid. You got to take a stress view in order to see that there is a hidden ligament injuries, and then you may need a very major surgery. So that is the one which has to be there. And what is in is, there is a bimalleolar fracture. CT scan is a must, because that's the only way you will be able to see the posterior malleolus and the way you are going to treat that posterior malleolus. Out is anterior posterior screw in a posterior malleolus. All of us, I have taught everybody that this is how you put the screws. But when you put the screws like this, you may completely miss the fracture. So what is out is anterior posterior screw in a posterior malleolus. What is in is a posterior anterior screw and a buttress plate if needed. That is an absolute must. Do not neglect a posterior malleolus. This was the posterior malleolus, which was fixed from anterior posterior screw. And you can see still the gap remains. The screw threads are in the fracture, and this is what has happened over the time, the osteoarthritis of the ankle which occurs. Posterior malleolus, what is out? All saying that 25% of the posterior malleolus you can conserve. And what is in is all the posterior malleolus, you must fix it up, because it's not the malleolus which you are fixing. It's the posterior tibiofibular ligament which you are fixing, and that's the reason all posterior malleolus, almost all of them, you must fix it up. Out for a distal transverse fracture. We used to always give a screw fixation for this distal transverse medial malleolus. And you can see it here. The screw is passing through the fracture itself. For such small distal transverse medial malleolus, it has to be a tension band. And this vertical wire, which is going to be at 90 degrees to the fracture, I feel it is a must. So that is in is a tension band wiring. Do not treat a distal medial malleolus with the screws alone, because that's not going to work all the time. Out is only what is the C-arm based reduction of the medial malleolus. All what we did in the medial malleolus up till now is from the outer surface of the medial malleolus, we saw the reduction. And that's not good enough, because that small piece, it can rotate anteriorly, posteriorly, and you will not be able to see the 100% reduction. So if you want to see the 100% reduction, make the incision which is going to be more anteriorly. And in is what is open the joint and see 360 degrees reduction. Open the joint and you will be able to see the lower end of the tibia and the medial malleolus joining. So often you will find that the fragment is rotated and you will have to derotate it in order to get that 100% reduction which you need. What is out is, in a transverse fracture, the static fixation. This is out is a static nailing in a transverse fracture at the isthmus, where 3 inches of hold of the nail is perfect on either side of the fracture. What is in is a reamed nail in 1 to 1.5 millimeters smaller than the last reamer, adequate size nail, not a canal stuffing, pushed by hand and not hammered except at the end, ream 400 and nail 385. On day one, full weight bearing on day one, forget about it, it will heal up. Ream 400 and nail 385. And in a fracture like this, do not do a PFN. Out is a PFN in a fracture like this because it's always going to create a problem. What is in is a DHS in such fractures. Don't forget your old DHS. That's the gold standard. And in a clavicle fracture, this is the non-union 6 months. You can see the full function. So for me, what is out is the clavicle open reduction and plating except in non-union. You can see all these clavicles. You try to do it, it doesn't work. All these nerves, they were there to 4 of them. I could identify at the end of it, them, there was only 1. What is in is conservation. In a literature, the drainage tube is against using it in any surgery. So for me, what is out, I have stopped using drainage tube in any surgery. In is a good closer and no tube. In conclusion, out, COVID changes, posterior malleolus and posteriorly, medial malleolus only, no C-arm reduction, out is static nailing in isthmus fracture, and PFN in that fracture should not be done, and a routine clavicle practice, and no drainage tube ever. Thank you very much.